Good afternoon, everybody. My talk today is about vertebral fractures, optimization of diagnosis and management. Here is my disclosure. And my agenda is simple. It includes the epidemiology of vertebral fracture, diagnosis and assessment of vertebral fracture, management of vertebral compression fracture, and conclusion. As regards epidemiology, vertebral compression fractures are the most common complication of osteoporosis. Some prevalence estimates globally as high as 25 to 50% of individuals over the age of 50 years. The European Vertebral Osteoporosis Study, which involves around 15,000 individuals from 19 European countries, stated that 12% of men and women between the age of 50 to 79 years old have vertebral compression fracture, and similar results were found by the Canadian multi-center osteoporosis study. The prevalence of vertebral compression fracture varies between countries. It's most prevalent in South Korea, followed by USA, Hong Kong, Sweden, till being the least in UK. This was reported in 2010 and 2015 reports. The most common sites to have vertebral compression fracture is the transitional zone between the thoracic and lumbar vertebrae, between T12 and L2, where 60 to 75% of vertebral compression fracture occurs there, followed by the lumbar area between lumbar 2 and lumbar 5. Why vertebral compression fracture is unique? It's mostly a clinically silent fracture. The patient usually comes no patient will come complaining from vertebral compression fracture. Usually it's incidentally or accidentally discovered on routine examination, radiological examination on the thoracic or lumbar area, either X-ray, MRI, or CT. The second factor is being an independent factor for vertebral and non-vertebral fracture, even without the presence of other risk factors. The third one is that it's associated with higher mortality rates, and to make it a little bit difficult, there are various definitions of vertebral fractures existing using clinical and morphometrical parameters. Vertebral compression fracture has a deleterious negative effect on quality of life of the patient, where it causes severe pain, spinal malalignment, increased days of bed rest, decreased pulmonary function, inability to perform activities of daily living, depression, and marked reduction of quality of life. To diagnose the vertebral compression fracture clinically, you have to have a high clinical suspicion. When you face a patient old age with risk factor for developing osteoporosis, with height changes and dorsal hump that could be accepted for most of the patients and most of their caregivers as a normal sequelae of being aged, then you have the clinical suspicion of vertebral compression fracture. To make sure, you have to detect vertebral change in shape or to search for a vertebral morphology changes through examination of a lateral film, plain X-ray film. This conventional approach is subjective. To improve the subjectiveness or to improve the visual identification and to make it a little bit objective, an algorithm-based qualitative method has been developed that states that assumes that all osteoporotic vertebral fracture starts in the center before being present in the vertebral ring. A major differential diagnosis of the morphological change in the vertebra with reduction in height is the non-osteoporotic short vertebral height, as will be shown in the next slide. In this slide, different forms of height change in the vertebra are present. In the A film, there is reduction in the height, apparent reduction in the height of the vertebra, especially in the central area, in multiple vertebra, adjacent vertebrae, with reduction of the disc space in between, with irregularities of the end plate that doesn't go with osteoporosis. This is Sherman disease. The next film, the B film, shows this reduction in the anterior portion or anterior border of T9 vertebra, with the presence of osteophytes in other vertebrae, sclerosis of the margins. This is an osteoarthritic or degenerative change of the vertebra, and this apparent decrease in the height of the anterior border is due to the anterior projection of the anterior border. The third one, or the C film, shows reduction of the height of T7, mostly in the central part, with reduction of the quality of the bone and the end plates as if they are drawn with a pencil. They are very narrow, very thin. This is an osteoporotic fracture. So we cannot depend on the morphology except if a well-trained radiologist or a bone health professional can differentiate between the actual osteoporotic reduction of the height of the vertebra against other differential diagnoses. Let's see if we can change or end this dilemma by measuring the height of the vertebra in millimeters or so on a plain X-ray film or DEXA. By using a transparent ruler, we can use a dead lateral X-ray film of the